Welcome to Protect, Suicide Prevention Training Podcast for Healthcare Professionals. I'm Manan, Consultant Psychiatrist, Founder, and Head of Faculty at Progress Guide. Good day, everyone. I'd like to acknowledge the traditional custodians of the land on which we meet. I myself am on the lands of the Yagara and the Turrbal people. I'd like to pay my respect to the elders past and present and their ongoing connection to land, wind, waters, and communities. Today is a special episode, and we are joined today by Paul Vittles. He's the Chief Facilitator of the Zero Suicide Society and is also the founder of Towards Zero Suicide community interest company based in York in the United Kingdom. Our paths crossed on LinkedIn, actually, as Paul was posting about the Join the Dots tour, the launch conference they had just done around zero suicide. Paul has had a really interesting journey, had an illustrious career that spans over 40 years. I'm not going to steal his thunder. I'm going to let him talk about it. But Paul, I would like us to get started with the phrase Towards Zero in the name of the community interest company, Towards Zero rather than zero itself. Is that a compromise to bring people on board?
I wouldn't say it's a compromise, but it's, let's say, pragmatic. Let's say it's informed. What we try and do in all our conversations is be as inclusive as possible in all the ways we need to achieve that, including pulling people into the conversation and not pushing them away. And I first started getting heavily involved in the global zero suicide movement, which is largely a healthcare-based movement, the Zero Suicide in Healthcare movement, which was started in Detroit in 2000. And that is a framework, an evidence-based framework for reducing numbers of suicides in healthcare. But the term zero suicide does get some pushback from people. And it's two main areas of pushback. One is at an individual level, if somebody has done everything they possibly can to keep a loved one alive or a patient or a client alive, and they haven't been able to do that, they find talk of zero suicide, it can be quite hurtful, that it suggests that all suicides are preventable and some clearly aren't. So there's pushback on that level. Also on a macro level, people often just say, well, you can't get the numbers down to zero, and they just treat it as a target, purely as a statistical target. And sometimes people put an S on the end, they put zero suicides, which makes it sound even more like a target. So when we did all our research and engagement with all of the people working in suicide prevention and all the people with lived experience, we found that if we used the term Towards Zero Suicide, everybody wanted to get involved in that conversation. It didn't push people away. And then we did a research project starting in January 2023, where we used the term Zero Suicide Society, which again we found was getting a lot of positive engagement. And we defined that before we started the project, as we launched the research project, we defined it as a society that is willing and able to do all it can to prevent all preventable suicides. And that's what we're trying to create. And then we mapped it out, we fleshed it out, we described it in enormous detail what such a society would look like and how we get there. But that definition and that careful choice of words was really crucial in pulling everybody into that conversation. So by saying prevent all preventable suicides in the definition of a zero suicide society, that was more inclusive. And then when it came to me setting up a community interest company to be 100% dedicated to delivering the Zero Suicide Society transformation program, I chose that terminology Towards Zero Suicide for the name of the business, a business for purpose, that I knew resonated with people. People would say in our research, not only must we get the numbers down, we can get the numbers down. And we'd say, how far do you think we can go? And they'd say, well, we can go towards zero. We can't get to zero, that's unrealistic, but we can get towards zero. By the way, there was another qualification to that, which is at a micro level, people do start to believe you can get to zero. At a macro level, 3,000 in Australia or 6,000 deaths in the UK just sounds too big, too hard. But if you go in an individual school or hospital or workplace, or small community or farming community, most people will want to try and get the numbers of suicides in that local area or that workplace or that school or that hospital down to zero, but certainly towards zero is everybody's aspiration.
Yeah, and I think the word aspiration is really important, isn't it? You kind of talked about targets. You can hit the target but completely miss the point. So, and the point is that we work tirelessly towards zero. So I just kind of love the fact that whether it's a compromise or not is a moot point. The idea is you're getting more people talking about it, more people coming to the table, joining the conversation. And that in itself is a beautiful thought that we are in this together and we all have a part to play. So, Paul, how did you get into suicide prevention work to begin with?
Well, I have personal lived experience going back many, many years, going back to 1980, when I lived in an old industrial area in the northeast of England, which was, experiencing dreadful times with factories closing, steelworks closing, shipyards closing, no apprenticeship schemes for kids leaving school. And we had a lot of suicides in our community, and I personally experienced loss back then. Our family experienced a suicide loss in August 2020. We lost a family member to suicide then. So it's touched our family personally. But I was in Australia. I was actually working in Australia and living in Australia in 2013. And I got pulled into it professionally through my professional work, which actually was in transformational change of all kinds, and community engagement and participative democracy and involving people in decisions that affect their lives. So I was working in traffic management and housing schemes and transforming businesses, and anything that was involved transformational change I would get involved in. And I was pioneering online forums from about 2008, where we'd get people from all around the world involved in discussions on how to break through in certain areas of thinking and acting. And in 2013, I was asked to facilitate a global forum on breakthrough ideas for suicide prevention. And it was the 2013 was the 60th anniversary of Samaritans in the UK, and it was the 50th anniversary of Lifeline in Australia. And so that kind of sparked it. And my wife happened to be working with Lifeline, and my son was working with Samaritans in the UK. But I ran that forum, and we had people who were currently working in currently working in suicide prevention in Australia and elsewhere. And we had people who were new to it. We deliberately, that's part of the methodology, bringing people who've never thought about suicide or suicide prevention before, from technology, from business, from wherever. And through that creative process, we came up with 10 big ideas, which we thought were breakthrough ideas for getting the numbers down. And the people working in suicide prevention tend to be quite defensive, as they often are in any profession, in any sector. If you've worked in it for 20, 30 years, you will get a little bit defensive. And they would tend to say, we just need more money. And there's only so much we can do, and we can't set high targets or high ambition because it's hard and it's complex and so on. The people who are new to it were coming in and saying, well, surely you should be able to get these numbers down considerably, if we just do the right things and do something different. And the technologists in particular were saying, surely we can have technological transformation in suicide prevention. So we got into some very interesting discussions, and it was formative for me, because it was the first time that I realized we can get these numbers down, that the practical actions are there to get the numbers down if we do this right. So, for example, on the technology side, people currently working in suicide prevention at that time tended to say technology is not the answer. It's all about human-to-human connection and human support. And they tended to be very dismissive of the technology. Whereas anybody coming in new to it would say, well, obviously, technology's got to be an answer here to try and detect people who are in distress or in danger and get human support to them. Use the technology to get the human support to people. So it's not an either or. And everybody's got their smartphones, and surely this is. So I did this exercise where I said to the people currently working in suicide prevention in 2013, when was the last major technological breakthrough in suicide prevention? And they all went very quiet for a couple of minutes, and then somebody said, "Oh, it was probably the telephone helpline in 1953." so that kind of shocked everybody. And then we came up with all these ideas we call digital life saving and tracking for life. And I even got to speak at TEDx Sydney about this in 2014. So I was talking about technology-based solutions for suicide prevention to about 3,000 people in the Sydney Opera House. So that was quite exciting. But some of those ideas have been implemented since, but some of them haven't, because there are lots of institutional barriers to change in suicide prevention, like everything else. So we have to try and find ways to overcome the barriers. But the solutions exist. It gave me confidence. It got me involved in lots of projects and national projects and international projects, and now in the UK doing lots of work here. And so the belief is there on two levels. One is we must get the numbers down because it's horrific to have in the UK 6,000 plus preventable suicide deaths every single year. But more importantly, we can get the numbers down. I absolutely believe we can get the numbers down towards zero.
Well, it's interesting you mentioned technological solutions. So we have just recently launched an app called Safe Flight Guide. And for the last, been working with a team in Vietnam who were doing the design, a team called Adamo Software. So these are techies, right? So they are not people from mental health. And they would kind of ask really kind of mindful questions. It will make you stop and think, because they work very differently to how we in mental health would work, and our logic is all convoluted, and they want things to be linear because they are trying to kind of do a design flow of what comes next and what comes next. And actually, there's so many different things. And it was quite good to be able to work with non-mental health people and to look at the same problems I have been looking at for the last 25 years. And it declutters everything. And because they bring it down to bare bones as to what would work and what might not work. Just say, for example, so they would ask the question like, but there are already safety planning apps. Why don't people use them? Or why aren't they effective? And you start thinking about what people, we've got so many apps, and they were asking about what is the unique selling feature of this app that we are building. And we started thinking about those little things which make a difference. So say, for example, the apps that we currently have do not produce a PDF which can be shared with family through WhatsApp or through text. So, okay, a simple little thing. It's a 1% improvement. So we can share the safety plan that's been done with the GP, with the psychiatrist, with the community psychiatric nurse, the care coordinator, the case manager, with a whole bunch of people, family and friends who need to know through a click of a button. So, and those kind of ideas come from people who are actually, because we are very stuck in our own way, and we always have done safety plans on paper, and no one then looks at it, and the safety plan disappears. So they were saying, oh, maybe sharing this will actually increase the acceptability. So it's a technological solution to a human problem. And then they kind of said, oh, but you keep talking about how much time gets wasted with people repeating documentation. Couldn't the person doing it on their phone share their safety plan with their doctor, so the doctor can put it on the system as well? So if in the emergency department, they have then access to the PDF which has been put there, and they can revisit that. And these kind of simple solutions actually come from people who look at the world much more simply than the complexity that we are often enmeshed in. So
it's I come from a world professionally working in research and consumer research and participatory research and user engagement, all that, user experience research, all these kinds of fields, and working with tech people who are very good at looking at the world that people are currently living in now. And if it's an online world, they're understanding how people are living in the online world now and trying to adapt to that, not trying to change people, but look at what people are doing and communicate with people how they're communicating now. And you step outside of that and you go into the healthcare system in particular, where the education sector to some extent, but certainly the healthcare sector, it's an offline world, or certainly was in 2013. It's very much an offline world, and they think offline rather than think online. So, for example, when lots of training started going online, they would take PowerPoint presentations that they would use for their in-person workshops and try and stick them online, and then they'd all be very clunky. People would say, well, that wasn't a very interesting sort of training session I've just been to. Whereas people who live in the online world devise things that are designed for the online world and for consumption in the online world. So you apply the same principles to suicide prevention, and what you get is people from the inside saying, yes, it has to be human contact, it has to be high touch, if you like, rather than high tech, and it's all about people sitting, opposite each other in a counselling room and so on and so forth, or it's delivering services in the hospital. But the people from the online world, especially the emerging augmented intelligence and artificial intelligence world, they'll say things like, well, okay, let's just have a look at the problem here. And incredibly ethical people as well. So they consider all the ethical questions. And there's always prejudiced people working in what they call the public sector who don't trust people in the private sector and think they're all out to just make as much money as possible. I mean, this is all outdated stereotypes and prejudice. But they're very ethical. So they'll say, okay, well, what's the problem? We're trying to get the numbers of suicides down. We don't want to do anything that harms people. We want to do things that help people. How can we put better detection systems in place to identify people at risk or in danger? How can we intercept, online conversations which are showing there's a high degree of risk and get messages to people? So we've got people working on various projects now that are incredibly smart people with incredibly, intelligent solutions to how to get the number of suicides down. But the main blockages they face are people currently within the system who think offline rather than online, whose idea of ethics is basically trying to stop anything from happening until it's gone through several ethics committee processes. And we say to them, this is a new approach that potentially can save lives. So what's the ethics of not doing this, right? Let's turn that question around. What's the ethics of delaying this process for 3 years when it could be saving lives for the next 3 years? So we try and have a different kind of debate there. But what they've come up with, these people, like for instance, the Tracking for Life apps, what they can do is somebody signs up for an app, and I'm working on a project now developing one called iTalk with a guy called Darren Barden, who's had 2 near-death experiences himself. And this is entirely funded from the construction sector, where there is an incredibly high suicide rate. So there's no government money involved, there's no grant funding involved. It's construction companies wanting to try and get the suicide numbers down, and they're funding this app. And on that app, you sign up for that, and you get asked questions daily about your self-rated state of mental health. And if you're showing any signs of any suicide risk whatsoever, you're asked whether you've had thoughts of ending your life and whether you've made plans to end your life, and you're directed to relevant support. Now, you've got to ask those direct questions. As you know, all the evidence tells us we've got to ask those direct questions, not shy away from it. If somebody is known, is within the health system, then Tracking for Life apps can monitor them when they come out of the system, when they're discharged from hospital. They can give permissions when they're well to be applied when they're not well. If they go anywhere near a known frequently used location, it can immediately beep a nominated person from their phone. And if it's somebody who's not known to the system, these kinds of people we know who are well one day and in suicide crisis the next day because of loss of job, loss of home, loss of breakdown of relationship, etc. For these people, the digital life-saving initiatives are designed to pick these people up through all sorts of different places. We can pick people up through their financial data. We can pick people up. We've actually got an analyst who can identify people in suicide danger from changes in their LinkedIn profiles, right? So the technology exists to help save these lives. The barriers are the institutionalized systemic barriers within hospitals, within the healthcare system, within government, within the education system. Basically, people who move at a glacial pace are the biggest barriers to saving lives. And in fact, some of the people, and this is very controversial, but I'm going to say it anyway, some of the people who are advising governments on suicide prevention, some of the professors at universities, some of the leading kind of suicide prevention experts, if you like, can become the biggest barriers to suicide prevention because they are the first to try and slow down this process of development. They're the first to say, let's be cautious and let's make sure this is all properly tested, and let's have a 3-year, randomized controlled trial, or let's make sure that, this has been through 17 rounds of the ethics committee before we even try and get this project off the ground. People in the private sector and people in community-based organizations are out there doing stuff which is saving lives. And that's what we've been doing in our recent tour, connecting up with all the Join the Dots tour has been connecting with lots and lots of people who are doing amazing things to try and reduce the suicide numbers, and who don't have those same constraints. They have a driving motivation to save lives, usually because they've lost someone themselves or they've had a personal crisis. And they don't want to spend their lives writing grant fund applications or chasing research grants or trying to make the case to governments. So they're either very specific about what they want from government and demand it from government, or they just get on and do it themselves.
Yeah, and surely with a life being lost every 40 seconds to suicide somewhere in the world, that has to be the approach. As you say, what are the ethics of not doing it? Like, where is the data stored is a significant problem for these applications. And I know it's costing me an arm and a leg to put the data on an Amazon web server, but there needs to be layers and layers of encryption for that. And if you haven't got the backing of governments and big grants, you just haven't got the infrastructure to afford that kind of things. Doesn't matter if you want to do good. It made my day yesterday. I got a text from a consultant who's based in Perth who was saying that actually patients are doing their safety plans and sending in the PDF back to us, so we don't have to write it all over again, and it's saving me time. And I connected up with a psychologist who runs an organization of 300 odd psychologists entirely online. And you can understand rural Australia. They cover massive geographical areas. And that would be almost godsend for them to be able to actually communicate across kind of online and be able to support them through that.
Yeah.
So you kind of hinted at
one thing to mention.
Sure.
When I was working in Australia, I was actually commissioned to do a project for the Department of Health in the most remote communities in Australia. And I went out to some of these remote mining, well, I wouldn't call them communities, mines with people living there, really, is a better way of describing it. They weren't really communities at all. But I went to one place where there were 2 GPs surgeries, 2 medical centres, and one of them had state-of-the-art technology and one of them had nothing, right? They were right next door to each other. And one of them, when I went in and said, how do you communicate? And they said, oh, we have, online sessions and we do online support. We also try and keep in touch with good practice around the world. We've just been attending an online conference, which was coming from the UK, from Cardiff. And so that was great. I walked in the next one and they were completely opposite, right? In the same place, in exactly the same place. And they said, I said, well, how do you communicate? I mean, how much of your communication is by email, for instance? And they said, oh, we don't have, we limit email access, and most of the staff don't have email, and none of the patients. We don't communicate by email because we're worried about the security issues and things might go wrong. So there's 2 completely different mindsets there in exactly the same place. So I think this is a lesson to us all that yes, you need to have the safeguards. Of course, you need to have security, and of course, you need to make sure that any online system is secure. But again, a lot of these private sector people I work with are more conscious of that than anybody, right? Exactly. So let's not have the prejudice about that. But if you've got a mindset of tech for good, right? Because again, a lot of the government policy at the moment is based fundamentally on concern about online harm. So everything that is done is driven by online is harmful or online is potentially harmful, and we must protect people from this online harm. And you have to say to people every now and again, well, surely there's another side of the coin there, isn't it, about tech for good, about all the positive things. It reminds me of Martin Seligman, the founding father of the positive psychology movement, who said that he was asked how he set this up, and he said he was on a plane. He was going to a conference on a plane. He was sat next to a salesman, and this salesman said to him, "So what do you do?" He said, "I'm a psychologist, and I work with psychologists and psychiatrists, and And we sort of mainly deal with depression. And the salesman said, well, that must be depressing. And he said, well, yeah, actually, it is quite a lot of the time. It is depressing, right? But so the salesman said to him, and so do you study what makes people happy? And he said, no, we don't, actually. We tend to study what makes people sad. So that was like the normal human reaction is, well, surely you need to study what makes people sad and what makes people happy. But we institutionalize a system that puts massive amount of resources into studying what makes people sad or depressed and not what makes people happy. And at the moment, we've got a situation where there's a massive amount of resource and effort and policy work going into online harm, but not online help.
We didn't plan this at all, but we somehow ended up talking about technology, the marvels of it, as well as the challenges of it, and how we kind of navigate that. So in the Join the Dot tool that you all did, were there particular learnings that you all came up with? Were there particular moments of insight that you all had? Because it's just recently concluded, isn't it? A few weeks back, I think.
Yeah, I'll just give a bit of context for it. So I actually did that project back in 2013 that I mentioned, Breakthrough Ideas for Suicide Prevention. And then after doing a lot of mainstream suicide prevention policy type work and setting up national frameworks for this, that, and the other, I then started working very much with the global zero suicide movement to look at where they were getting the numbers down and how they're getting those numbers down. So if I heard that in Detroit, for example, where they got the numbers down by 75% in 4 years, I wanted to know how they achieved that, right? So I could see if we could apply that elsewhere. When I then did a project in 2018, 2020, that was around what I call the transformation model for suicide prevention. So we were already coming up with ideas around top-down and ground-up approaches, around what we could do in workplaces, around the technology, around designing out suicides in our built environment, or designing in suicide prevention. So I was doing that kind of work. And then I started working with Steve Phillip from the Jordan Legacy. Steve had lost his son Jordan to suicide in December 2019. So we'd started working together. And we did this project or initiative called the Zero Suicide Society initiative. And that was, we defined it as this society that is willing and able to do all it can to prevent all preventable suicides. We went out and we interviewed people working in suicide prevention, NHS mental health consultants, leading campaigners, hundreds of people with lived experience of suicide. And we said to them, basically, how far can we go and what practical actions will get the numbers down towards zero? And we documented all of this, put a report out in July 2023, got masses of feedback from people, loads more suggestions, put out a second edition in September 2023. We devised the Zero Suicide Society model and framework. It's like a building blocks model with a foundation stone and these two keystones and all the building bricks above that. And it's also a dual framework for, we call it a jigsaw picture. So there's all the pieces in the puzzle in terms of solutions. So it's got the healthcare piece and the education piece and the workplace piece and the tech piece and so on in there. And then we wanted to roll it out as a demonstration. So we decided to take what we call the M62 corridor in the UK from the Humber to the Mersey. And we did that for a couple of reasons. One is that we knew the Global Zero Suicide Summit was taking place in Liverpool on the 24th, 25th of June. So we thought we'll get there in time for that and participate in that. And we'll start at the Humber, we'll work across. Also, we thought we're going through two of the English regions with the highest suicide rates. So Northwest actually has the highest suicide rate of all the English regions now. And Yorkshire Numbers had increasing suicide rate over the last few years. So we're going through those regions. We're going to some of the places with the very highest suicide rates in the country. And also we thought what we'll take is to take our model, we'll take all the pieces in the puzzle, and we'll get the very top professional experts within each of those pieces. So like the healthcare piece, we've got Joe Rafferty, the CEO of Mersey Care Trust, the co-founder and chair of the Zero Suicide Alliance. We've got Joe to speak to that piece. And also we'll get leading lived experience experts, by lived experience, campaigners. People like the Three Dads Walking have walked the full length of the country 3 times and raised over £1 million and got 170,000 signatures on their petition for suicide prevention education in schools. So we've got all these people I sent out invites to them all, thinking we'd get maybe a 60-65% acceptance rate, given the nature of what we're trying to do, given the time of year in June in the English summer, given that it was in Scunthorpe, not a place that many people, even in England, know, just on the south side of the Humber River and the Humber Bridge. So we sent our invites out. We got an unprecedented 90% acceptance rate, 90% accepted. So we had this incredible group of people. And that's the video that you saw, the sort of showing all these different, and we're covering different perspectives that are not normally covered at suicide prevention conferences. So we're going deep into the non-healthcare issues. We're going into, we had a session on injustice related suicide, suicides that are caused by systemic injustice and institutionalized cruelty, right? This is, we had, in the UK, we had a teacher, a head teacher, who took her own life after a schools inspectorate, Ofsted inspection in her school, downgraded her school from outstanding to inadequate, told her that they were going to announce that publicly in 90 days, and she wasn't allowed to talk to anybody about it, because that was part of their process. So 54 days into that 90-day death sentence, effectively, she took her own life. We've got a scandal here in the UK with the post office that accused sub-postmasters of stealing money, and none of them did. It was a computer system that went wrong. But 3,500 sub-postmasters were accused of stealing money, and some of those took their own lives, and many of them were imprisoned, you know, and it's been an absolute scandal. So we're going into these kinds of issues. So after that launch conference, we went across the routes, and we had, I'll just give you some highlights, right? We had a panel in York, where I'm based, where we had 5 people representing, we called it inclusion and missing pieces in the puzzle, right, the panel. We had 5 people representing groups that have a higher than average suicide rate, and none of them are mentioned in the National Suicide Prevention Strategy. So we did that quite deliberately. Here's 5 groups of people with higher than average suicide rates that don't even get a mention in the National Suicide Prevention Strategy. So that's deliberately challenging people's thinking there. We went to Bury in Greater Manchester, where they didn't have, before we arrived on the 18th of June, they didn't have a suicide prevention partnership group. They didn't have a suicide prevention strategy. Just lots of wonderful people trying to do something. So we used our day there to try and pull people together, get community organisations together. And the council gave us the local theatre for the evening. You know, they gave us a room in the local theatre to get everybody together. So we gave talks about having high ambition on suicide prevention, because we say low ambition costs lives, right? Low ambition kills people. And so, and we say collaboration, not competition, because competition costs lives as well. Being competition in suicide prevention kills people. You know, you've got to be collaborative. We have a philosophy, everyone must be a priority for someone. There's no place for priority groups and prioritization in our model at all. So we pulled all these people together. So we entered Bury in the morning on the 18th without them having a suicide prevention partnership group or a strategy. We left at 8 p.m. at night with 50 people signed up for the partnership group, and everybody wanting an ambitious suicide prevention strategy, you know. And we went to Wigan, we went to a place called Rebuild the
That is
Pub.
definitely, sorry, that's a really great example of joining the dots. You know, if the individuals who were doing work themselves, by themselves, in their own little cocoon, and just being able to connect people together, bring that is a great example of joining the dots.
It was, I mean, yeah, it was a great example, because we were, the way this works is that I kind of coordinated the whole thing, but I worked with what we called our local energy sources, right? So in each location, I picked somebody who I thought had the energy more than anything, the ideas and the lived experience, but the energy more than anything else to make things happen in that area. So in Bury, it was Rebecca Jackson. Rebecca had lost her 16-year-old daughter to suicide, and disappeared for 5 years, and lived in her back bedroom and learned how to sew and make stuff, right? So she came out and set up this place called the Big Fandango, and it's a combined community centre, it's a suicide prevention training centre, and it's a arts and craft workshop. And she brings people in there, kids with social anxiety, women with postnatal depression, older people with chronic loneliness, men, women, everybody comes in. And the kids will make hoodies themselves. You know, the women will make sort of handbags and shoes and also, I mean, what shoes is maybe an extreme example, but they'll make all sorts of stuff. And when we actually said to Rebecca we wanted to come to the workshop and come to the Big Fandango, she took our Zero Suicide Society model and she turned it into a quilt. She actually made it up for us as a quilt, which is beautiful, So we now got this quilt we can carry around with us. But Rebecca hosted us, brought various people together. Jim from the council joined us, and we went to other places in the borough that are doing amazing work, and we all got together in the evening. So it is that joining the dots, but you need key people who have that energy, who have that. And Rebecca is one of these people who she's not. She's not out there doing lots of talks and media interviews and stuff like that. She said, I never wanted to be famous for having experiencing a tragedy. Basically, I want to just do stuff. I want to just help people. So she does that every single day. She helps people. And in Liverpool, I'll just give you one more example. In Liverpool,
sorry,
Debbie
just
Rogers,
to kind of mention, because I don't want to lose the thought. So we went from high-end technological solutions like apps all the way to a quilt. And both are great examples of innovation. And kind of Rebecca's story reminds me that, these stories are data with a soul. I know that we talk a lot about research and kind of what works and what doesn't work, but these stories are so inspiring. And in terms of suicide prevention efforts, I don't think we do enough to bring these stories to the forefront. Yes, a personal tragedy indeed. And from that tragedy, from that adversity, comes out this amazing story of seems like touching people's lives and making a difference. A doer isn't in it for the name or the praise, but wants to make a difference. How inspiring is that?
I think that it brings out people's character. We also have to remind ourselves, and this is again part of my background in terms of the research. I've been an executive coach since 1996, and I'm trained as a counsellor. And in my research work, we identify what makes teams work and what are barriers to change and all these kinds of things. So one of the things that I often talk about in my workshops is how if somebody experiences bereavement, suicide bereavement, or if they experience living through a suicide attempt, it does change them. There's no question it does change them. And we've got all these amazing examples of post-traumatic growth, for example. But it doesn't change them in other ways. They are the same person they were the day before their suicide attempt or the day before their suicide bereavement. If there was somebody who was, let's say, very much a policy kind of person working in that kind of policy area, they naturally go into those areas. So they try and reduce the numbers of suicides by changing policies. If there's somebody who previously was quite heavily involved in running charities and things, then they'll probably set up a new charity. If there's somebody who was a prominent sort of public speaker or media personality, then they use their public speaking skills or their media connections. So that's just natural that people do that. But we have to remember there's also lots, and for all those ones that we see with that high profile, it's like the iceberg, right? I mean, there are hundreds and thousands of people who are out there doing other stuff and doing it often very quietly. And so we join the dots with people who are working on these incredible tech projects, and most people have no idea that they're even doing it. But that's their thing, right? Somebody else is out there just running, a craft workshop, or we've got a guy who lost his son to suicide and didn't really know what to do, but he just goes around pubs and clubs and plays songs to people and talks about mental health and looking after yourself. Everybody's doing it their own way. But Debbie, I'll just tell you about Debbie Rogers in Liverpool, in Book, John's place. She lost a brother to suicide in 2019. And she said the whole system had let him down. Sean had been let down by the system, and she tried to do everything she possibly could to keep Sean alive, but wasn't able to do so. And she thought, well, I'll set up a kind of place that might have kept him alive. I'll set up the kind of place that might help other blokes like Sean to stay alive. And so she set up Sean's place, and it literally was like a community hall, 6 chairs, inviting blokes in. Last year at Sean's place, they had 3,000 blokes came through Sean's place. 3,000 blokes. It's quite extraordinary. The NHS now, refers people to Sean's place. It's what we call social prescribing, right? So it's an amazing place. It's grown through Debbie just listening to people, listening to blokes, what's going to help you, how to create the right environment, a safe, supportive environment. People say, we had a night there as part of our tour, and we had 8 blokes on stage saying, I wouldn't be here, I wouldn't be alive if it wasn't for Sean's place, if it wasn't for Debbie. And they said things like, I went everywhere else, I didn't feel comfortable, I didn't feel as if I could speak, I was just angry and upset. And here I walked in and they said, oh, hi, you want a cup of tea? It's just like immediately everybody was down to earth and they made me feel welcome. And so everybody opens up, and people say men don't talk. Well, in Sean's place, men talk a lot, about everything. And we had a choir, they have a choir of hope. This is like about 40 blokes who've been to the edge, right? Who formed a choir.
Sorry, again, I don't want to lose. This is such an important thing, right? So what is it that we are doing in the statutory sector which clamps people up, where we can't connect? There is something that happens in Sean's place and what Debbie has managed to do, which is magic, like people opening up and talking.
Yep.
What is stopping us in statutory sector, whether that be here in Australia or whether that be within the NHS? And I'm made in the NHS, spent 18 years in the NHS, very proud of what the NHS has done for me and having worked in the NHS. But what are we doing in the statutory sector? And why is it that we are not able to replicate the same thing? Like, what are we caught up in that stops us from providing that cuppa to someone who is in distress and meeting them as a human being, meeting them where they are and connecting with them? And it sounds like that's what they're doing. It comes back to this whole idea of human connection and being listened to, and someone taking my emotional pain seriously and empathically connecting with me with genuine empathic concern to try and do something about it. And even if they can't, just giving me a patient ear so I can open up.
I mean, in our research, we heard time and time again from people that what we need, and these are key pieces in the puzzle, we need safe, supportive spaces. We need community-centred solutions. We need accessible mental health services when we need mental health services, but we don't need to go anywhere near mental health services if we don't need them, right? So this is what we hear from people, and we just need someone to listen. And, I don't necessarily need clinical services, but I just, first and foremost, I need somebody to listen to me. So from that need, from that clear identified need, what then happens is, in somewhere like Sean's place, it ticks all those boxes. So they turn up, it's instant access. They get support, they get a safe, supportive space, they get community-centred solutions, they get access to the help they need instantly. And they just find a peer support group, and everything falls into place. And whatever they want to do, if they say, can we go fishing, next week there'll be a fishing trip organised. If they say, I want to join a band, they'll organise a band, With their experience with the system, with statutory services, is at the moment, sadly, over the last few years here in the UK, and we just had a change of government, so we're interested to see what happens there. But their experience has been, they go to the GP refers them to National Health Service, mental health services, they're put on a waiting list. So they've just told their GP that they're having thoughts of ending their lives, and they're put on a waiting list. And sometimes it's a waiting list for assessment, not for treatment, it's a waiting list for assessment. And in some cases, it's 3 months or 6 months. So the whole system fails. And I'll come back to that. Then also, they go into the mental health system where they are assessed after this long wait, if they're still alive. And then they're sometimes referred into services in the community, which doesn't make any sense, because if they're assessed in the community, that would then filter the number of people who needed to actually go into the psychiatric care system and minimise the number of people on waiting lists. So the whole system has failed. Now, we just had a new government, a Labour landslide, a new Secretary of State for Health and Social Care, Wes Streeting, whose first day in office made a speech and said the NHS is broken. And he's just effectively made another speech saying the social care system is broken. Now, thankfully, that's honesty. We've been wanting that kind of honesty for some time. And obviously that's Labour's way of saying we need to accept the problem as the first step to solving the problem. But the people who've been in power for the previous 14 years, with a large P and a small p, had got to that point of defensiveness, and they weren't able to say the things that the new Secretary of State is saying. They weren't able to say the whole system was broken because they were part of that system that was broken, and they were part of sustaining that system. So you've got lots and lots of staff who are doing their absolute best to work within a broken system. You've got people struggling to, to provide the basic care that people would rightly expect in this day and age, in the 21st, in the 2020s. What you'd normally expect, you wouldn't expect to be on a waiting list for 6 months if you've told somebody you're thinking of ending your life, right? But that's what was happening. But they weren't able to stand up and say, this is completely broken, this is completely unacceptable. We haven't got the time and space to listen to people. We can't create a safe, supportive space. We're not structurally or culturally set up to provide solutions in the community. We're set up to provide solutions in hospitals. And in Liverpool, I interviewed somebody who had been diagnosed with an eating disorder, and they were put onto a general psych ward, and it damaged them even further, So you've got all those examples of the system actually harming people and making things worse. Now, obviously, we hope the new government will bring about some positive changes there, but they also need to accept that the solutions are not within the system. The system needs to change and be reformed, but we need to accept that we need more assessment in the community. We need a shift to primary care and into the community, away from secondary care. We've been saying these things for years, of course, and we need to see services like Sean's Place and the Big Fandango as absolutely fundamental to our health and social care and general care and support system. They're not outside the system, they are actually part of the system. They are not of a lower value or a lower meaning because it's somebody's voluntarily set up a service, right? And is running a service on the smell of an oily rag, I mean, it's kind of, these people are literally lifesavers. They are saving people's lives every day, and they are taking pressure off the statutory services every single day. And they're giving instant access to services. And people say, well, how do you do that? I mean, how can you have statutory services with a 6-month waiting list and 1 million children on the waiting list in January last year, 1 million children on the waiting list for mental health services? So how can you give instant access? Well, it's because they so passionately believe that people must have instant access to services, they've made it happen. And they haven't taken no for an answer. If you drop into Sean's Place, you are given support immediately. If you need counselling, a session will be organised within a couple of days, right? Because they exist to just do that.
Yeah. So I think we've kind of touched on 3 things. One is within the statutory system, the capacity of the system as such, in terms of how many people are coming in, how many people are going out, and what's actually delivered in the middle. So the processes, can we have paperwork for proper work? If you are spending more time with a square box, i.e. a computer, rather than a round face, something's gone wrong in the system, right? So there's something about that in terms of the capacity and the processes that are driving that, and you hinted at a few of those. There's something about capability as well for staff to care. You cannot pour from an empty cup. So if you're working in the NHS and you're feeling completely run down, and we have to be fair, COVID has taken its toll. And if you're working within a broken system and the government is saying the system's broken, it does wear you down, you can't pour from an empty cup. So in terms of staff capability, how do staff maintain a degree of sensitivity to people in suicidal distress? So if you are coming across 15, 20 people daily working in A&E in suicidal distress, you will naturally get desensitized to people's emotional pain. It's almost like a protective response to keep your kind of life force alive in a way. and how are we looking after our staff in the statutory sector. And then we kind of touched on some of the big cultural issues, whether that be just resistance to change. This is how we have done it. And your example of 2 GP surgeries side by side in Australia, both rural and remote, 2 very different approaches is quite an eye-opener in that space, that sometimes there are cultural things, or even the role models that we have currently got who have gone through our systems in a particular way. So as I know it was tongue-in-cheek 17 rounds of ethics. I don't think it's that far off that, because, you know, applying for a grant is so much work, your heart would sink. Yep. So capacity issues, capability issues, cultural issues, you kind of you touched on some of the things that we might need to do in terms of improving our processes. So what are the pragmatic conversations we need to change some of the processes around access, matched care, being able to respond to people's needs at the right time, in the right place, somewhere to go to, someone to speak to. So there are lots of pragmatic exchanges we need. There was something about capability, and in terms of capability, I think there's a huge amount of learning exchanges that need to happen, particularly around maintaining a degree of sensitivity to people's emotional pain, because it's so easy to get burnt out, and it's almost like a defense response. And then for our culture, so there would be new practices that would develop if we had those learning exchanges. And there's something about honest exchanges around the culture within which we work. And if we had those honest exchanges, maybe we will have pathways towards zero, which combine together the best of the statutory sector and the non-governmental organizations coming together in events like Join the Dots Tour, say, for example, where you get to hear amazing stories of people like Rebecca and Debbie who are doing it, who are absolute proof that it can be done. And there's so much learning over there to be had from them.
Yeah. Yeah, and I attended a conference yesterday, which is run by somebody called Becky Inkster, Dr. Becky Inkster, a University of Cambridge academic who does amazing work. And she runs a conference called Digital Innovations in Mental Health. And we had a discussion there. It was about creativity and art and music, and really wide-ranging exploration of all the different factors that can enhance people's mental health and reduce numbers of suicides. And we were talking about belief systems and people's expectations, and how you will get, like kids, for example, in some old industrial areas.
Is Becky the person who works with Dr. Akim Sule and does hip hop as well on the side?
Yeah,
I think
yes. Yeah, she's the hip hop.
So Becky and I, we were together in Oxford when I was training, actually. So It's a small bird. Yes, do know Becky very well.
She's great, and yes, some people call her the hip hop academic.
Yes, and, she is the hip hop. She and Akim Sule, they do a lot of work using pop culture and hip hop culture, and write papers about kind of lots of mental health issues.
And Becky is a bridge between the work that I do and the academic world that I'm not part of. I work with the academic world. For instance, we're trying to set up a transformational change centre at the University of York, where people who've never ever considered suicide, business people doing leadership development programs or MBAs or something like this, they will be given suicide prevention as an option to study as a transformational change challenge. So they will literally just see the graph for the first time and see the numbers not going down for 16 years and say, well, clearly, you need to do something different to get that trend line going in the right direction, right? So I'll work with academics in those kinds of projects. But Becky's a good bridge because she's got the academic rigor, but she's also got the practicality and the technology now as well. So she can study through her work. She can identify people's state of mental health, like from the lyrics that young people are writing in their songs, or the songs that people are listening to. So there's all sorts of wonderful things we can do if we marry up this all these different disciplines. But we were having this conversation yesterday about expectations, and I was saying that many years ago I was working with kids in families in these old industrial areas, old mining towns, and old sort of areas that used to have shipyards and steelworks and so on. And the kids' expectations of like coming out of school with qualifications. Nobody expected them. Didn't expect themselves to get any qualifications. The parents didn't expect them to get any qualifications. Most of the teachers didn't expect them to get any qualifications. So guess what? They came out with no qualifications, right? So expectations is absolutely crucial. Now, what we found in suicide prevention is that the expectations of lots of people in the system seem to have been falling over the last 15 years as the numbers have stalled, as the numbers of suicides haven't gone down. And people have got quite despairing about it at times. And even some of the advisors to government and some of the people who are leading the suicide prevention charities are very quick to tell you there's only so much we can do, resources are limited, we're not going to get the numbers down by a lot. Let's set a target of 10% reduction. And I would say to them things like, well, do you believe, and based on your research as well as your own experience, do you believe that most suicides are preventable? And every single person asked that question to would say, yes, most suicides are preventable. Not all, but most suicides are preventable, and all the research shows that. So I'd say to them, okay, well, let's just do the maths here. Doesn't that mean that we should be getting the numbers down by at least 50% rather than aiming for 10%, So this expectations problem has arisen, and the belief system problem is there, where you've got people in governments, people who are setting the policies, people who are advising the government, people who are running suicide prevention charities, and people who are running hospitals and so on, who have a low ambition or a low level of belief of what we can do in getting the numbers down. Now, if I go and get together our 600 people with lived experience of suicide, they will all answer that question by saying, yes, we can get the numbers down by at least 50%, and we must, and we can. And here's the practical things we can do to get them down. And they're full of energy in terms of going about doing it. So we need to help the people in the system who've been ground down by the system to the point where they don't believe they can actually do anything about suicide anymore. And they've set these really low ambitions, and get them working with these incredibly high energy, high ambition individuals with post-traumatic growth who are saying, look, we can do this, we can do this, we can do this, and we've got to imagine if we knit all these people together, again, joining the dots is about joining together the people, the organizations, the issues and the places, so that everybody connects, collaborates, and puts all these practical ideas into practice. And then you get this positive effect of people believing you can make change, believe it. And of course, everybody needs to see the numbers going down, not going up, and then saying, right, okay, we're doing the right things here. But there does seem to be a big belief system within the system, a big belief problem within the system.
So that's, I think we've been chatting for almost an hour, so that would be a beautiful note to end on, is the danger isn't that we, the danger isn't that we won't reach our target. The danger is that we will reach our target if it's just a 10%. So kind of what we are hearing from you, Paul, is...
There's a famous quote. Yeah, there's a famous quote by Marianne Williamson, which was popularized by Nelson Mandela in his inaugural speech as president, where he said, our greatest fear is not that we are inadequate. Our greatest fear is that we are powerful beyond measure. And so there is an element of that. People don't believe they can get the numbers down, but they're scared that they maybe can. And they're not really trying. They're trying in terms of working incredibly hard and getting ground down by the system and the broken NHS and everything else. But they're not trying hard enough in terms of doing things differently, in terms of radical approaches, in terms of challenging the barriers and saying, that some of these institutional problems that we've got need to be fundamentally changed and changed quickly. And with regard to things like risk assessments and safety plans, I remember going to a presentation in Australia, in Perth, in 2014, where Dr. Matthew Large from Sydney stood up on the platform and said our risk assessment systems are killing people, right? And we need to change them and move to individual safety plans and try and keep everybody alive, not decide who gets to be high risk, low risk. Now that was 10 years ago. It's taken us 10 years to get to a point where people are saying, actually, yeah, that's the right thing to do, and we should be doing it across the entire system.
Well, there's still organizations. There's still organizations who use high, medium, low as a way of categorizing risk. It's kind of a personal agenda of mine to keep waging against high, medium, and low. And, it's not worth even the paper it's written on, because risk is so
Yeah.
dynamic when you're categorizing risk in that way. So,
and then you've got the Golden Gate Bridge in San Francisco, where the community said put a net under it. If you want to save lives, put a net under it, and they finally got a net early this year, right? After 87 years of campaigning for one. How do we stop having to wait 10 years or 87 years when these practical solutions are there already, ready for us to implement? So yeah, I always like to finish everything on a note of hope. I tell people I'm in the hope business. That's what I do. I'm in the hope business. And the hope comes from the practical things we can do to get these numbers down. There are so many practical things we can do in healthcare, in education, in technology, in designing out suicide in our built environments. Let's just implement all of these. It's all in our report, moving towards a zero suicide society. Let's just implement them, get the numbers down, get the belief from seeing the numbers going down, raise the expectations, raise the ambitions, be open and honest when the system is broken and say it's broken and do something about it. Get people from outside government, construction sector and everywhere else. Get people, technologists involved. Don't fear the technology. Get these amazing people involved and just say, right, we are going to get these numbers down by at least 50% within the next 5 to 10 years or whatever target you want to set. But just get up every single day believing you can get the numbers down. You will get the numbers down. And we will also, and the Samaritans have published a report from London School of Economics showing that preventable suicides cost the economy £10 billion a year in the UK. So anybody who thinks it's about the money should just have a read of that report and say, look, if you're worried about the finances, then just get your investment head on and think of suicide prevention as a sensible investment, and let's get the return on investment as well. So it's about the human case, the moral case, and the business case. We should all be just trying to get these numbers down.
Thank you, Paul. That's a beautiful note to end on. There you heard it, listeners. Ending on a message of hope. Paul seems to have managed to harness the power of people's personal stories. He called it post-traumatic growth, and the energy and the passion that comes from that, and is on the way towards zero suicide, engaging people, connecting people, joining the dots. Thank you, Paul. You've been very generous with your time. I could listen to you all day. And thank you for all the work that you are doing in this space. Thank you very much.
Thank you.